active when she's ready.
Awesome, welcome. So I tried to keep this very broad because I was hoping we would have some primary care or pediatricians joining us today, but we don't. So I apologize when things get very much into doctor language. It's broad enough, I think, to encompass all of us mental health professionals here today. 1 second. Okay, how's that look on everybody's end? Just the PowerPoint screen? I might take it as a yes.
Yeah. That's great, yes.
Thank you. Let me see if I can move my people so I can see everybody down here. Nope. Oops. Sorry for this. Okay, so today, initially I was tasked with the job of discussing professionalism, maintaining professionalism, and I thought, I don't even really know what the question is that people are wanting to ask or wanting us to present on today. So I took in my own direction. And if you have further areas you want to discuss or things that people were really interested in, definitely stop me. There's a lot of places in which we can talk today. And so I kind of changed the title a little bit to just professionalism. What is it? How do we teach it? Or how do we learn it, attain it? And how do we maintain it? So I thought it was a little more important than just how do we maintain it, but many of us are educators in different ways. And so I think it's important we know, how did we gain professionalism? How do we teach other people to be professionals? And how do we maintain it? So maybe. So I just want to start by opening up the discussion with what is professionalism? Let's see if I can. So what do we think? What is professionalism? See, everyone here would have had as hard a time as I did coming up with this lecture, right? Professionalism, I think we all have this kind of internal understanding of, okay, I know this person is professional and I know this person is not acting very professional, and it's much easier for us to talk about what is not professional behavior than it is to talk about professional behavior, but it's really hard to define professionalism. But I want you guys all to give it a try. What do you think of with the word professionalism?
I'll take a stab there, Dr. Lillard.
Thanks, Nick. I appreciate it.
Yeah, let's be semi-pretentious. Holistically maintaining the standards of your job.
I like that. Yeah. Can you see that when I write? Oh, gosh.
See a little red mark.
Yeah. Well, that's because I can only get an H.
Oh,
I'm not going to be able to read
I've tried to do that. Yeah, that ain't easy.
I need my iPad, which is needs charged at the moment. Okay. Holistically, say it again one more time, Nick.
Holistically maintaining the standards of your job.
Holistically maintaining the standards of your job. I like it. That's a good one.
Go ahead, Laura.
When I think of professionalism, what it's come to mean for me over time, especially working within mental health and taking on a lot of the pain and burdens of patients and other people, it's become important for me to think about the emotion regulation component of professionalism. So kind of the boundary of which it's your life and then your job. And depending on the culture of a place, that Venn diagram overlaps a lot. But for me, I try to think about sometimes needing to compartmentalize or like leave personal life problems or emotions at the door to be able to do my job best. And that's often how I really think about it with the kind of work that I've done so far.
I think Laura somehow saw some of my slides ahead of time. I'm not sure how.
Oh no, I really didn't. Maybe
no,
work together. I'm like tuned into you.
Yeah, no, that's great. I think that especially when we're talking on the maintaining end of professionalism, emotion regulation falls under, in my mind, it falls under self-care. And that's a piece we're going to talk about, it of how having good self-care having ways to be resilient in the face of possible burnout is really important for us to maintain professionalism. And we'll talk a little bit about compartmentalization and how it's both can be positive and can be negative. I think it's very important, especially, I mean, I think many of you here have heard me talk before about my forensic practice, but I hear some really atrocious things, and those can't come home with me, or I can't keep doing what I'm doing. But I think Laura made a really good point on the other end of things. If there's stuff going on at home, it also cannot come into work, and if I'm maintaining my professionalism. Wonderful. Who else? Amanda looks ready to give us a awesome child
I say deep.
social work answer.
Well, I don't know about deep or awesome, but you know, when I think of professionalism, I think about the way we represent ourselves, we present ourselves, and we conduct ourselves within our professional setting.
Yeah, I like that.
I'm short.
Wait, say all those words again. Present ourselves.
Represent ourselves and conduct ourselves.
I like those. I like the broad definitions we have going on. Okay, so I'll switch to the next one, but you're still not off the hook on answering questions. All right, so sort of similar to the last question, but I want to know what you guys thought when you heard that I was coming today to talk about maintaining professionalism. What were you expecting, or thoughts about what this lecture might be about? Or just the title when you saw it today?
I was just thinking it's just ways of how you conduct yourself, or how you are an extension or representing your work and the company or the program you're involved in.
Yes, that's great, Mariah. Yeah, I like the thought of you are a kind of extension of your either agency or profession. And that's kind of a big responsibility for us to have, is to think about all of our actions being the representation. And we hear that a lot. We hear patients come in and say, I had a really great social worker that I worked with a child 5 years ago, and they talk very highly of social workers. Or I worked with a psychologist once and they just didn't understand me. They didn't know what I was talking about. They didn't get to my level, and they have a not so positive understanding of that profession. So I will just cheat and tell you guys what went through my mind walking my dog when I was thinking about what am I going to talk about. Here are some of the thoughts that came to my head. Because remember, my title, Maintaining Professionalism. I was like, well, how do we teach professionalism? Well, we should, when we talk about maintaining, we should talk about regaining, right? What if somebody lost professionalism for a period of time? Can they regain it? How do we help them regain it? What happens when somebody lacks professionalism? That's kind of easier to talk about, right? I think of someone who's not professional. I go to like boundaries, and a person has sex with their patient. That would be unprofessional. Then I got a little more nuance about, different characteristics currently with telemedicine. Are there different levels of professionalism, things we need to think about when it comes to telemedicine? Thinking about self-care as a piece of professionalism. And then, how do we become professionals? There's one I didn't put on here and actually didn't have enough. I think this lecture is going to get too long anyway, so it might be worth coming back to, is this thought of social media and how do mental health or healthcare professionals maintain professionalism in the setting of social media. So if you guys are interested in that, I think that might be a worthy topic for us in the future to really kind of delve into what's appropriate, what's not appropriate, because I think it's important. It's a great way for us to reach patients and to affect change, especially in times like the pandemic when everyone's at home and lots of people are on social media. And how do we get across to them? Here are some ways to lower your anxiety. How do we do it in a way that doesn't affect clients' confidentiality? And how do we do it in a way that keeps us in good standing within our profession? Okay, so let's talk about defining professionalism first, because it seems like everybody had some ideas and possibly struggled. And I can send out the citation. Most of today's lecture comes from a book called The ABCs of Clinical Professionalism. It's actually written in the UK, so some might not, some of the language, there's some language differences. They talk a little bit about, you know, their what is it, the NHS, their like, oh, somebody help me with the words, their medical system, that universal medical system. But I think a lot of it matches pretty well with what we're talking about here. And so when we think about professionalism, there's different areas of professionalism. There's the area under social domains, there's areas of professionalism under ethical domains, and there's areas of professionalism under legal domains. But one definition that has been proposed is that clinical professionalism is a set of values, behaviors, and relationships that underpin the trust the public has in doctors, mental health professionals, easily interchangeable there. And so, yes, it's the things that we do to represent ourselves. It's the relationships that we can build with patients, relationships we can build with colleagues, relationships we can build with the public. But it's also our values, personal values, our professional values, and it all comes down to trust. Professionalism comes down to what is the public's trust in us as mental health care professionals? What are our colleagues' trust in us as mental health professionals? And I thought it was interesting to think about these 6 domains, and we'll get to most of them today. The first domain of professionalism is ethical practice, right? Each of us in our own specialties has guidelines that look at what is ethical behavior, what is not ethical behavior. And kind of going off of that, there's also a lot of regulations about professionalism. So not only do we have this like ideal ethical code of conduct that we're thinking of, at least in psychology, but we also have a licensing board, and the licensing board has determined there's like legal regulations that involve professionalism. And sometimes they go hand in hand. Sometimes the legal works against the ethical, sometimes the ethical works against the legal, so it can be kind of a sticky situation. Another domain is reflection and self-awareness. Another one, and I kind of think of reflection and self-awareness as this kind of like lifelong learning. We're not necessarily like start your practice in 2021 and never change what you do until you retire in 40 years. It's likely that you're going to have to change and adapt and grow your practice within what's going on around you, within new science and technology. And so it's important that as a part of professionalism is being a lifelong learner. Responsibility and accountability for actions. So this can take a bunch of different directions, but one that comes to my mind is that we should be talking about errors. So in medicine, this is considered like if they have a bad patient outcome, they'll do what's called like an M&M, mortality and morbidity assessment, where they will present on the patient, what happened, why it happened, and things that we could do differently in the future to keep it from happening again. And I think that although I don't think social work, counseling, psychology necessarily has a system in place like M&M, it's something important within our organizations to think of. Are there ways for us to talk about treatment or evaluations that just didn't go well? Something happened that, you know, maybe we weren't as effective as we wanted to be. Maybe it wasn't successful like we thought it was going to be. And I think reflecting on taking responsibility for some of our actions is very important. Respect for patients, that's a key, right? It's all about this trust the public has in us. Working well with others is another domain. Teamwork, and then social responsibility. And this one gets really interesting. And we'll look at it in the next slide a bit. But this social responsibility suggests that we have obligations even outside of work to maintain our professionalism. And sometimes I think that's really unfair. You know, it's a little bit unfair that I shouldn't end up on High Street at a bar really drunk in front of potential clients, right? Like I'm outside of work, I should be able to do my own thing, but to a degree, we have a social responsibility, and we kind of carry our professional identity with us in a lot of directions that we go. And I think also a social responsibility, this is where we should be thinking about like advocacy, social justice, and what role it might play in our professional identity. I know that social work does a great job in advocacy. They do a great job in really wanting to make differences in social justice matters. And then I look at psychology, and maybe Laura can speak about this too. I look at psychology, and we kind of skirt around the edges of that. And we can kind of say, oh, this is our professional practice, is it doing therapy, but I don't really need to be standing up for things maybe outside of that practice. You have any thoughts about that, Laura?
Yeah, just echoing what you said, I do think that that's potentially not as intertwined within coursework in programs. And so it kind of depends, it seems like, on where people end up after their training, the setting of how much that's emphasized, or almost like personal values being separate than professional values. So it's kind of more like up to the variability of the individual versus a culture of the profession itself.
Yeah, I like that. And Amanda, would you agree that social work makes it kind of a professional identity value?
Yeah, absolutely. I think definitely within the mission and the ethics of it.
It's interesting to think about. We have such similar trainings, but little differences too. Okay, I know this is really busy and kind of weird words here, and this is where I think that the UK stuff from this, but I thought it was really important. So the authors of the ABCs of clinical professionalism talked about 3 different, a Venn diagram of areas in which professionalism is characterized. And so they broke it down into clinicalship. So just think of like clinical work and what parts of clinical work we need to, what do we need to do in our clinical work to be a professional? Workmanship, so other things maybe outside of direct clinical work, but still part of our job. So maybe it's all the didactic, all the like meetings we have to go to, the relationships and networking that we have to build, working with our teams and our colleagues and our professional development there. And the last is that citizenship, and that citizenship is where I think that social responsibility falls. And so that one's kind of interesting. So that's the very bottom box we have here. And it talks about, their idea of citizenship for a professional healthcare worker is to avoid substance and alcohol misuse, to adhere to professional rules and regulations, and to function according to the law. So unfortunately, we can't go out and just break a whole bunch of laws and probably keep practicing as a healthcare professional. And so I'm going to look at the circles all separately, and then we can look at it in between, how they interact with each other. So that was citizenship. Let's look at clinicianship. So the clinical work. This is, I think first off is the idea of do no harm, because that's kind of the basic tenet of medicine and of helping others. And so with that comes respecting patients' autonomy, communicating in a clear and effective manner that they understand, they talk about altruism, being altruistic towards patients, attentive to their needs, treating them fairly without prejudice, and being empathetic. So that's what they're looking at with the clinical. With the workmanship, they're talking about, acting responsibly with colleagues, acting responsibly towards society, positive attitude towards professional development, continuing ed credits and going to conferences and lectures and workshops. Working well as a member of a team, being attentive, sensitive to the cultural background of colleagues and patients. So again, some of that social responsibility starts to be more and more important in terms of professionalism here. Being accessible to colleagues, And then if we look at, I think this is interesting, the clinical and the work kind of coming together and that overlap. We look at like still respecting colleagues, being receptive of constructive criticism. I mean, that to me, that's an important professional development skill. Reflecting on one's actions and seeing it with a bent of improvement. So again, that's taking that constructive criticism. It's doing getting a feedback from maybe supervisees, maybe a patient, and really kind of taking it to heart and not allowing yourself to immediately get defensive. Kind of hear what they're trying to say and see how you can maybe make things different in the future. They talked a lot about being cynical in your job, which I thought was interesting. Then within clinicianship and citizenship, they talked about this is that respecting the client's confidentiality and privacy, acting in a responsible fashion, sound judgment and decision making, and being honest and living with integrity. So I thought work and citizenship, they only had one, just being punctual was important. And then I realized, whew, that gets harder and harder with all the demands of life, is to be punctual. And then when they put all the Venn diagram overlaps with all three of them, they talk about acting with confidence in one's duties, which I think comes along with being competent to do what you're doing. I think you're oftentimes, and hopefully accurately, your confidence overlaps with your competencies. Behaving reliably in dependable ways, behaving with composure, being accountable for one's actions, and taking a dedicated approach to one's work. Thoughts on this? Okay, so we've talked about defining what is professionalism, all these things that go into an individual being a professional and having professionalism. But how do we teach it, or how do we learn it? They said that there's really no consensus on the optimal teaching strategy, and that likely in general practice, it happens with a whole bunch of different areas all coming together. But they said part of the key is socialization within the professional setting. So, which makes sense, right? We can sit down and we can read a book about how to do CBT for anxiety. But until you go into a clinic, start working with patients, start observing a supervisor work with patients or other clinicians work with patients, it's really hard to understand some of the nuances, right? I could read the manual and I could give it straight from the manual and I could follow it to a T, but I'm probably leaving out some things. You know, we might innately have higher levels of empathy, but we might need to learn how to best approach a patient, how to give that kind of informed consent in the beginning. And so all of that is kind of learned through practicums or learned through internships while we are in training. And these are important because it teaches communication skills, collaboration, respect, teamwork, and the ability to maintain professional boundaries. And it's particularly in my work, professional boundaries is very important. I think it's important for all of us, and it's different in all of our practices. It's different with every type of patient that you're going to see. And so I think it's really important that we learn what is the appropriate boundary in this situation versus this situation. I mean, a boundary violation in a forensic context could be giving an inmate a pencil, right? But in Amanda's clinic, if she hands a child a crayon, that's probably not a boundary violation. They're probably not using her, manipulating her to give them a crayon. And so important to know your different settings and professional boundaries, which all comes down to kind of role modeling, or that, Bandura and his social learning theory. It's the idea of that we're kind of modeling what we see our supervisors do. Now that, for many of us who are supervisors in some context, means we have a big responsibility. Like, we need to be on top of our professionalism to be able to, even just through observational learning by these trainees, understand what is professionalism in our setting. You know, if we aren't doing well and our communication skills are struggling, or we're having a tough time respecting and working with members of our team, our trainees are going to take that all in and learn a lot of that cynicalism that we may not want them to learn. So that's really important. I think it kind of means that supervisors need to be extra aware and reflective of their professionalism. And it's important that we keep in mind that everyone comes into professional training with personal values. And so it may be that we have some of these professional development, professionalism values already kind of innate in us. And maybe that's what makes us successful through professional training programs. But in the training programs, we're also learning our professional values. What are the attitudes, behaviors, and language that is associated with this professional identity? And we do that through formal and informal observation of others. We do that through demonstrations. And we do that by assigning trainees tasks with increasing autonomy and complexity. And so again, it's kind of all about that scaffolding or role modeling for our trainees. And they talk about there being like formal ways to teach professionalism, so like a didactic about professionalism, but that we also do it in informal ways when they're just seeing us interact in the clinical rounds or interact in an MDT session. And there's also this like hidden curriculum that is going on as well, which is kind of interesting. And that's like the context, the social, the cultural context of the work environment and how, you know, the work environment as a whole, so the CED as a whole or Chestnut Ridge as a whole has a culture. And we are, by bringing trainees in, influencing them and teaching them based on this culture, even if it's not specifically talked about. And so that again makes me think of all the levels of responsibility we have with our trainees. So I thought this was an interesting prism. They called it a prism. It's a bit complicated. Look at clinical competence. And so let's look at the kind of left side. This triangle starts at the very bottom of just we need to instill knowledge, teach them fact gathering, teach them, you know, have students do a fact-based test after reading an article. Then they need to know how to do something. So how do they interpret and apply? We do that through case presentations, essays, and they talk about showing, so a demonstration of their learning through simulators or, you know, over here we have what's called like a clinical competency examination. And the last is that you integrate your performance into your practice. And then your professionalism also going from novice to expert with attitudes, skills, and knowledge. Your professional identity is going that way. So it's a little complicated. We start with kind of giving the cognition, go up to behavior, and that's how we're having people gain their competencies. So the last one they called a basket of professional qualities, which I thought was interesting. They said first we input. So you think about like as a trainee coming in, they're coming in with their own levels of judgment, their own levels of excellence and moral contract. So that's kind of like their innate values. And then we're going to teach them and show them and demonstrate and role model all these things: knowledge, clinical skills, commitment, respect, integrity, compassion, altruism, personal responsibility. And then out, we hope that they master these skills, become autonomous, and are able to self-regulate themselves. So with teaching comes assessing. How do we know that our teaching, that through their training program, an individual has come out with a solid sense of professionalism? And the authors talked about having this conscientiousness index, and how do we use that to assess people's professionalism? Because I think it's important that we have these competencies in professionalism, but what does it actually look like? And so they had some ideas, which I thought were kind of interesting. So they talked about like attendance showing professionalism, right? Are they showing up to required didactics? Are they punctual in showing up to these didactics? Do they sign in and out of sessions? Do they tell people if they're going to be absent from work? Do they attend agreed upon meetings? And do they give proper notice for any changes? And then they talk about like assignments, completing and collecting information accurately, administrative data. Do they log are their clinical documentation done efficiently? Is it turned in time? Do they, the very beginning, do they bring all the required documentation? You know, things that you need to get started with HR. And then do they have the coursework? Have they been reading the coursework? Have they completed the online the modules, the didactics they're supposed to? And then, you know, kind of how are they doing completing evaluations? All right. So we've talked about what is professionalism. We've talked about how do we teach it and how did we learn it? And now let's talk about how do we maintain it, because I will go with the assumption all of us have attained a level of professionalism for whatever our specific practice is. And so kind of three ways that I think about how we maintain professionalism is that we are very reflective, and we have reflective practices that let us kind of see, we take some time to see what we are doing and whether what we are doing is effective and efficient. Is it working well? Are there tweaks that we can make? Could we do this in a different way? Open to kind of changing and adapting our practices as we go. Another way is lifelong learning, maintaining those competencies. For example, MMPI 3 is just coming out. Well, I was trained on the MMPI 2 probably, maybe the 2RF. But I need to know the MMPI 3. And so going to a day-long workshop that was super boring was important for my professionalism to know this new test. Same thing when new intelligence testing comes out, new types of therapy, like scientific evidence-based therapy comes out, we probably should go to a conference or we should go to a workshop so we can maintain those competencies. As for some areas in medicine, they encourage board certification, and with their board certification, they have to recert every 10 years. And the idea is we make sure that they're up to date with the current knowledge throughout their career. And the other is just having this positive attitude about lifelong learning, getting excited about a patient problem that maybe you don't even know that much about, and doing a quick lit search about it. And the last part of maintaining professionalism is self-care. This is a whole topic in and of itself that I think we have on our schedule, if I remember correctly. It'll be coming up at some point. But we'll talk a little bit about burnout today. So this was really interesting. They called this the 2-bucket approach to promoting well-being. And it was interesting because it took a personal on one side, taking personal responsibility as a way to promote well-being. It also looked at the organization and the environment of wellness in which you are working and how that affects your well-being. And I thought those were very good things to think about. So at a personal level, what responsibility do we have to promote well-being within ourselves? And I liked their ideas. Set time each week to pursue a duty in your practice that you enjoy. So there's probably something about your clinical practice or even just your job as a whole. So maybe it's teaching for me. Maybe I really enjoy teaching. And so then I should set aside some time each week to practice teaching, to research teaching, to engage in a teaching opportunity. And so it's just trying to get you to remember, there's a lot of tasks that we have to do and the requirements of our job, but there's a reason that we've chosen this job. There's something that we really do enjoy. And if we can try to have that piece of joy at least once a week, then it can help keep us on the right track. Next was to take your vacation time. Don't store it all up unless you have good reason to. Take your vacation time. It's there for you. It's important. You need it. Maintaining a healthy diet and exercise, talking to a partner, talking to your support system, making sure, keeping people aware of how you are doing physically and emotionally. They talked about avoiding delayed gratification, which was kind of interesting. It was this idea that many times healthcare professionals will say, I'll just do that hobby when I retire. I'll just keep putting it off. Or once I get promoted, then I can take up this new task or this new hobby or this new activity. And they talked about not delaying that gratification until you retire, but rather let's work on that now. Let's work on getting those hobbies and those interests that you have. current. And then also I thought I really liked about this approach was it talked about what is the organization that you work within, what is their responsibility to create or promote an environment of wellness. And they said that they should offer honest discussions. So you should be able to discuss concerns and issues that you may be having, and that they should be open to some of those discussions. And this is where, like, I was talking about the M&Ms earlier. The organization should encourage healthcare professionals to talk about medical errors. Have those M&M sessions. Have really hard M&M sessions if you have to about where this error came from. What was the issue? What did we do that wasn't very good, and how can we make it better? And I think the same thing should apply to mental health professionals talking about, treatment issues as well. Oftentimes, we may have, because we're not working, maybe we're working with different client populations, it may not be that we have a suicide of a patient of ours that we could actually do an M&M. But I think there's a lot of things that maybe we don't do as effectively that would be good learning opportunities for everyone. It's learning for the person who made the error. It's learning for the person who saw that an error was made so they know not to do it in the future. But this can be really hard, and people get really defensive, and sometimes they're then discouraged to have these sessions and talk about errors. They talked about having a self-assessment for providers, that although providers know that self-care is important, we don't always, could we give them a little handout that says, check all these things that you are doing. So many of them equal positive self-care, or you're not doing any of these things, so maybe it's time that you work on your self-care, or maybe these are lots of warning signs for burnout. And the last was to develop flexible schedules, which I thought was interesting because I think maybe a positive to come out of COVID is the realization that flexible work environments, flexible schedules are good for employee well-being. Giving them some of that extra room is important. I think it's good when we're considering young families, families of all kinds, even people caring for elderly family members. Like, we don't always know what's going on in the lives of our colleagues and what they're kind of dealing with at home. But if we could offer this flexible schedule where, I can say for me at least, I have quite a bit of flexibility. For example, last Thursday, I had a kid homesick from school. Now, thanks to COVID, I could still see my therapy patients. I just had to get their permission that a 5-year-old might be jumping in and saying something silly in the middle of the therapy session. Thoughts on that before I move on? A couple of slides on risk factors for burnout and illness in doctors. Doctors was their language. I think healthcare professionals in general can apply here. Some of it you'll see is more focused on physicians. But I think many of us can relate to this. These first are risk factors related to the occupation itself. So our clinical practices involve emotional demands of patients. And so for physicians, that might be surgeons whose patients are close to death. For us, that may mean despair, right? Patients that are suicidal, patients that are kind of on the edge or brink, or patients that are close to disability. And so there's a lot of emotional demand with the patient populations that we see. There's also high expectations about the power of medicine, the power of therapy. They're probably going to come in and think you're going to cure them in the next session, and not understand it's kind of this lifelong process. Or for anyone doing things like PCIT, they're going to assume you're going to fix their child. And when you sit down and say, no, I'm going to work on your relationship with your child, and they're like, no, wait a second, this isn't supposed to be about me. And then lastly, they talked about the ease of access to prescription drugs and how to use them is a risk factor for physicians in particular. And this comes from the idea that like physicians have a really high burnout rate, and they actually have a really high suicide rate compared to the like national average. Other occupational structural issues is heavy workloads and long work hours. I don't know about you all, but I know sometimes I have to take work home. I might have to work on the weekends. I might have to just work really late one night. I imagine with most of you here are working with children, but when you're working with kids, sometimes you've got to work maybe an evening shift because the parents want to come in after work and they want to come in after school, and that means it's not during normal business hours. They talk about sleep deprivation, and they talk about the psychosocial work environment, which I think was important to consider. It's this idea, it could be like workplace bullying issues. The one that they didn't have, but I wanted to put in there, was systemic racism and gender disparities, and how those kind of structural issues within our occupation can be hindering our ability to be resilient and successful, and can be a risk factor for burnout. It gets hard fighting the battle that maternity leave is not a vacation, which might be a battle that I've fought a time or two. And then maybe it's a lack of cohesive teamwork, and the person feels like they've got to manage this all, everything's on their shoulders, and they've got to manage it by themselves. Now we have risk factors for burnout in the individual risk factors. And so this one was a little bit more, I'm going to say some of this might be us, but some of this might just be more physician related. But I talked about compartmentalization with this kind of idea of having to like split yourself into different areas and not being able to separate your work life and home life. I talked about maybe some personality characteristics, particularly of narcissism, perfectionism, and compulsiveness, and how a lot of those are what helps make healthcare professionals successful. That's how they got through their professional training. But at the same time, it also sets them up for burnout. And last, they talked about there being in general an excessive sense of responsibility, desire to please, guilt for things outside of their control, and self-doubt within healthcare professionals. And so lastly, what are some risk factors for burnout that are barriers to seeking help? Why don't healthcare professionals get the help they know they need? And this became really salient to me during the pandemic, because I know that WV Medicine worked really hard to set up, I don't even remember the title of it, Amanda, if you remember, let me know. It was like they offered therapy services to healthcare workers throughout WVU Medicine to help kind of deal with how they were dealing with COVID and the pandemic. And they were available for drop-in calls. You only had to give like an hour's notice if you needed to talk. They had all this availability. And, you know, no one showed up to, or very few people showed up to any of the sessions. And it ended up, I imagine it's probably still in place somehow, but it's not in place. I mean, we had like faculty were taking hour slots to be available to the frontline ER nurses that were just getting pummeled with COVID cases. And they didn't see, and people were not, people weren't attending, people weren't requesting it, people weren't, and we kind of all wondered what is going on. And I think some of these barriers to seeking help might have been what was going on a little bit, although I'm sure there were other issues. First off, that we started maybe before they were, unfortunately, they weren't maybe too burnout yet. They were still kind of in that like adrenaline phase of the pandemic. But some of these barriers can include concerns about confidentiality, like, can I talk to this person who also works with this agency? Are they going to tell my boss? Are they going to tell other people? Are they going to keep it confidential? And then I know within a lot of, for physicians in particular, there are concerns about disclosure of mental illness and regulations. I know there was some talk a while ago that if a physician has a mental health diagnosis, then a whole bunch of these like regulators need to know about it, and they need to track what medicines are on and how they're doing. And I'm sure there's good reasons for all those regulations, but I think it stops people from getting the help they need. Or a lot of times I think, you know, physicians might go to another state, particularly Pennsylvania being so close to us, go into Pennsylvania and privately pay for mental health services so that nobody knows about it, which does not help with mental illness stigma. And then psychological barriers, they feel some shame and doubt that, or shame and embarrassment that they might need to reach out for services. They may see illness as a mark of failure, and they have a difficult time taking on a patient role. I thought about me attending therapy services, and I'm like, I would be a terrible patient. I would be like, nah, that's not how you do CBT. No, that's not what cognitive restructuring is supposed to look like. Okay, now you're just trying to reflect, I can imagine I might be a very difficult patient. And then systemic barriers include underfunding, constant reorganization, and this kind of healthcare model of a business. Sometimes we jokingly call it the machine. There's like this huge entity or enterprise that's working, and we're fit in there somewhere, but that leads to kind of everything maybe being about how much did you bill? Did we get reimbursement? What is insurance doing? It becomes way more about, unfortunately, to keep the doors open, about business versus like, I just want to help these patients. I don't care how much they pay to talk to me in therapy. I just want them to have less distress than when they started. And we're going to stop with this great acronym for the word burnout to prevent it. They talk about the B, balance work and play, understand our limitations. We're not superheroes. We don't need to be martyrs. Recognize it in ourselves and in our colleagues. Nurture the next generation. Bring the fun back into work, which Amanda did in a big meeting we had recently. She stood up and said, well, one of our values needs to be fun, which is great. And then teamwork. How do we work in groups? How do we work, rest, play, and reflect all together? So that is what we have about professionalism. Any thoughts, comments? Silence.
It was very, very good. Thank you so much. That is a hard topic to write about. Like, I did not know what you're going to be able to discuss, because I think it's just something we don't think about. We just kind of do. I mean, nobody really like taught me, maybe my parents, on how to act, but I think it's also hard too. I think professionalism is different with your audience and who you are, speaking with. So like with Mitra, I'm a little bit more personable. Actually, that's something I need to work on. I'm like an open box, book. I don't mind. I'm not shy to tell you my emotions, how I feel, especially when it comes to anxiety and things I've experienced. I'm not shy about it because I think it could help somebody. So I'm just an open book, sometimes too much, too vulnerable maybe. But yeah, I sometimes try to remember my audience, who I can maybe curse in front of and who I can't. It really is hard sometimes, especially when you're new. You have to test the waters, I guess, or you ask around.
Or you wait till somebody curses first, then you're like, oh.
Yeah, exactly. And if somebody doesn't, I ask if it's okay. So I think there's just depends on where you work. And I think it would be very hard, if I was in a position that you guys are in, because I'm an open book. I think that, it'd be hard not to share, I don't know, examples of my own with somebody to open them up. I don't know if that'd be appropriate, but yeah.
Yeah, professionalism, it's something that we all know exists, but it's very hard to pin down. What does that actually mean? And how did we actually learn it? Because it just kind of, you're learning on the go usually. And I think that is what helps us to be successful. You don't have to think too much about, am I doing something professional? It kind of becomes your identity, and then what you do is professional, versus having to be really hard. Because if you're having to think, okay, when I walk into this patient's room, I've got to be professional. I can't curse at them. I can't yell at them. If you had to tell yourself all of that, you're going to totally blank out on what am I assessing? What am I trying to have a conversation? I can't do a therapy session and help you if I'm in my head thinking about how to be a professional here. But if we all go back to the first time we stepped into a clinical setting, we were probably going through, okay, don't fidget your feet around too much. Don't play with your hair. To some degree, we had all those kind of little structural things we had to think about.
And also, I think, talking about earlier about the different environments, I kind of got ruined. I started out right from my internship as my first professional job at Mount Olive.
Yeah, that'll mess you up.
So, to say the least, that cussing was accepted. It was a cultural up there. So, and I'm not saying that every time I interacted with an inmate that I was just, dropping bombs, but I mean, at first, when I first got hired in and started working there, I was cautious of that. But then I really learned it was a style of communication. And even in therapy sessions, talking in that manner helped build rapport with that population, and to letting them know sometimes that I'm not sitting on this high mighty chair above you and using all these proper terminologies. Like, I'm a human being here too, trying to listen to you. So when I had 5-6 years of that. So leaving that and working in a community setting, let's just say with my first job, I had a lot of sensitivity training. And it wasn't because I was being not mindful of other people. It's just I had worked in that environment for so long, it became a bad habit. It literally became a bad habit. And I will say it over and over, I don't care. When you hear someone use foul language in a professional setting, it does look a little bad, where it looks a little bit, you know what I mean? So I had to learn. It took a while for me to break that bad habit. And still today, sometimes I will slip up and I'll instantly be like, I am so sorry. I hope I didn't offend you. Let me know, blah, blah, blah. So yeah, it does definitely depend on your environment in which you were exposed to and how you view it as well too. So it's been a lesson learned.
It's a lot of learning, and going into those correctional settings, you had to learn a lot of professional boundaries. You had to learn,
Yes.
yeah, I might be able to cuss with that inmate, but I can't give that inmate a pencil. It sounds so silly.
No, well, you can't be so chummy. And, and also too, at the same time, it was not allowing them to, like, I can't do this for you. You know what I mean? I would usually start, if I had a complaint, it was like, I got your complaint. I'm here reviewing it. These are the things that I can help you with. All right. And if they would start going off on something else, I'd be like, I'm so sorry. That sounds like a great plan, but that's out of my hands. These are the things A, B, and C is what I can do. And I learned real quickly, if I was honest and not given empty promises, that went way further with the inmates. I never had an issue. The 5 years that I worked at there, and even in the juveniles, I never had an issue with an inmate. Now with staff, yes, but inmates, I had an easier time dealing and rebuilding rapport with them than I did with some of the staff, because it was also that correctional mentality. I was on the mental health side, so I was on the treatment side. So it was battling that security mentality and trying to provide services. And, you'd get the comments like, oh, you're a hug thug, or you would hear them say, oh, you're going to go cry to Mariah's today in your session. And, you would try to be like, hey, but, it was just a different mentality. It was hard. So yeah, me having that as a first job was definitely an experience. And to say that I got out of it because I felt like it was affecting me too. Like, it was a negative environment. It was working in a negative situation. And being so young, it was starting to crush my, how when you graduate college, you have this full of hope, like you're going to change the world. It was starting to crush that. So I had to get out. Even though I love criminal behavior, and Colleen, I'm so jealous. Like, I wanted to be a forensic psychologist. I love criminal behavior and studying that kind of stuff. But I will say that the criminal, like the prison environment, I thought that was something I would love to work in. And after 6 years, I was like, I don't know if I want to do this rest of my life.
I do think it's interesting. I think it's much easier to go from really strict boundary setting, like in Mount Olive, to a community setting. Because if you had someone who had worked 5 or 6 years in the community where they could self-disclose and they could, get close to patients, and then you're shifting into that correctional, that's a really hard transition. And so I think you actually did it the right way that made it a little bit easier, although it's interesting to hear you talk about things you still have to learn. I'm still not empathetic enough to be an effective therapist.
Trouble when I was working with DRS, I would have some of my colleagues, because I was supervised psychologist in West Virginia and I surpassed my time, but I am licensed in North Carolina. And I had, when I left the prison and went to communities, vocational kind of work with psychologicals, I had a couple of my colleagues call me out saying, you know, you question them more, as in like, you're trying to be like, I think you might be lying about this. And they were saying like, you know, in this environment, this population, you know, this is dealing with a disability population. You should be more empathetic, and you're not here to try to, and that was another experience. My guard was up sometimes, and that was a shift I had to reprogram my thinking a little bit. That not everyone's trying to strong arm me, not everyone's trying to pull one over me. You know, it was those kind of thinking and thoughts.
Yeah, I think you're right, Colleen. I think and Mariah, what you're talking about, like adapting your professionalism to the environment is important. And you know, when you talk about, like, I worked in a maximum sentence penitentiary before I came here, and
I can't imagine you.
right, I hated it. Like and same thing where I like loved the inmates, but the workers were the worst. Like
Right.
it wasn't even the inmates. I totally enjoyed working with them, but one of the things that I learned very quick was keeping very rigid boundaries, and you're dealing with professional criminals. So like they knew how to just, and you know, I even had to have them call me Miss Newhouse. Like if they called me outside of my name, I would correct them, because if you gave them just a little bit, it would be more and more and more and more. So keeping that professionalism was so very important. And so you're right. I think it's very rigid. And I agree, Colleen. I think going there, being very rigid, and then coming into a community setting is.
Although it takes a lot of still restructuring, like Mariah was saying. Yeah, that's very interesting. Speaking of like the officers, the hardest for me, I worked in the federal prison in North Carolina, and it was Butner houses the transgender inmates within the federal system. And, you know, thinking back 5 or 6 years ago is when I was working there, and we got called so many names simply because I would refer to the inmate as Miss whoever. And the officers, you know, they were not tolerant of different gender identities. That was a really big kind of eye-opening shock. And you got to play that balance, right? Part of your professionalism in that setting is you've got to be a colleague to those correctional officers, and you've got to be a therapist with very strict boundaries to those inmates, and it comes into conflict. But if you don't build that professional relationship with that correctional officer, you put yourself in a dangerous situation of them not responding to that emergency call.
Yeah. Yes. 100% agree. It was definitely game if you do, game if you don't kind of a situation in a lot of the cases of it. Yeah. And you're right, 100%, Amanda. It was. I found more friction with staff than I did with inmates, and just trying to do my work, just trying to do what I was supposed to do there. And they would also like, they would say, you're only allowed 6 sessions. And I would tell them, like, you know, in community life, that's not even, typically we even try to go up to 52 weeks. And if you don't make any progress, that's almost a year, you know what I mean? So then you start talking about, you know, transferring over or whatever. No, they would 6 sessions. And if we went over that, it was kind of like, well, you're showing favoritism.
Right.
And,
like even the time frame, like even when I would give somebody an hour session, which is typical, right? Like it's, are you having sex with them? And it's like,
no, yeah. And it was
providing therapy.
There was stories. We did have a doctorate level psychologist at one of the facilities did get, you know, in an inappropriate relationship. I know it occurred and happened, and that's the reason why there was things in place. But yeah, it just made things difficult to get things done. And then you really felt like, man, there's really no rehabilitation going on in the prison system. They don't really want it. They don't really want that to happen. They want security. And when we would have complaints, like from the psychology board, technically security kind of trumped some of those, like, you know, going down the queues and doing those evaluation of being in the hole for so long about their mental capacity. We would go door to door and ask them if they were okay. One inmate pressed charges, were filed a complaint saying that was a violation of his confidentiality. Well, given that we were low staff and that they were already in a violation in the prison and like doing a punishment kind of stint down in the hole, it was kind of like, this is how it's going to have to be done. So there was no violation in it. But I mean, we had 2 psychologists that had to be reviewed over that. So, I mean, yeah, it was a lot. It was a lot of maneuvering, but I'll stop because I can talk about, I'm sure all of you all, we could write books about working in a setting because it's interesting. There was never a dull moment. I will tell you that.
Yeah, thank you so much. Maybe we should have that as a topic. Colleen's face like.
Someone else can lead it.
Thank
I
you
do
guys
like
so
the
much.
idea, Colleen, though, of professionalism, like with social media. I think that would be a great topic.
I do too. I do too. Absolutely. Yeah. So we
Yep.
could definitely talk about doing that topic. I think it'd be really interesting. I really appreciate all of your time today. In the interest of time, though, we're a little over our time. So I just want to make that final announcement. Our next session will be taking place on July 7th, and Colleen will be discussing diagnosis. So I think that'll be a very interesting topic because I think that that's a complex one.
Yeah,
All
that's
right.
another, like, could you throw more into 20 minutes for me?
You can do it. I believe in you.
All right.
Thank you, everyone. You have a
Bye.
wonderful rest of your day. Bye-bye.